All right, chapter 31, head trauma. The other chapters we went over this morning, I've already uploaded to Canvas. Just FYI. Also, your research papers are on Canvas. There is a quiz on Canvas. There is lots and lots of other stuff on Canvas. I suggest you get on Canvas and check it out. All right, we're good. Whoa, homie.
Where's that at? On Canvas?
It is. It's on Canvas. So, today we're going to talk about head trauma. We're going to go over the anatomy of the skull and the brain and what a head injury is and how to treat it. All right, EMTs Matt and Lewis have arrived on the scene of a motorcycle collision involving a single patient who was ejected from his bike when he struck the side of a car. The patient, a male in his 30s, was not wearing a helmet. Matt and Lewis' initial impression is that the patient, who is not responsive, who has an airway, is compromised by facial bleeding. Dun, dun, dun. So, what are the first steps they're going to take?
Manual immobilization.
First step is going to be what?
BSI C-spine.
All right, second step,
C-spine.
C-spine. Third step,
Sure.
ABCs. What findings would lead the EMTs to suspect traumatic brain injury? Thanks for joining class, homie.
You're welcome.
It can mess with your people.
Yeah, can mess with your pupils. What about all that facial injury and stuff?
Unless they would be a little sunken wound.
Could be.
Right.
Okay. What types of head injuries may have occurred from this mechanism of injury?
Brain bleeding.
Okay, what else? Closed head injury, concussion, pretty much anything, okay?
This is on the second one. Is it possible that he would have cerebrospinal fluid leaking out of his
He
ear?
could, he possibly could. How do you check that?
You do the halo test.
Uh-huh. All right, so head injuries can be life-threatening and can lead to permanent disability. The patient's mental status can make assessment very difficult. And you need to recognize very promptly that they have a head injury, and the proper treatment are critical to the good outcome for your patients. All right, the skull. The cranial skull actually surrounds the brain. The face is made up of 14 bones. The basilar skull is the weakest portion. That's why you see basilar skull fractures. What are some of the signs of a basilar skull fracture? Anybody know? We're going to get into it. It's called battle signs and raccoon eyes. Yep. Some of the basilar skull bones are thin and perforated extensively by the spinal cord, nerves, and blood vessels. My computer's running really slow today. I don't know why. The brain occupies 80 to 90% of the space inside the skull. So when impact occurs, it does not have a whole lot of room to move. Right? It's supposed to be, but there are some that I really wonder about. All right, all three layers enclose not only the brain, but also the brainstem and the spinal cord. All right, these are your meninges. The outermost layer is the dura. The middle layer is the arachnoid, and beneath that is the pia mater. So you have dura, arachnoid, and pia. Okay, and like Chad said earlier, CSF leaking from the nose or ears is an indication of a basilar skull fracture. Any bleeding within the meningeal layers can be fatal within minutes, especially an epidural bleed, which is common from a lacerated or ruptured artery. The arachnoid membrane and the pia mater are separated by the subarachnoid space. It's a lattice of fibrous, spongy tissue filled with cerebrospinal fluid. This kind of gives you that little cushion. Okay? Not a whole lot, but it's a little. The cerebrum is not attached to the inside of the skull. It's sometimes called the little brain. The cerebellum controls your equilibrium and it coordinates your muscle activity. The brainstem is the most primitive and best protected part of the brain. It is tethered to the skull by numerous nerves and vessels and controls most autonomic functions of the body, including cardiac, respiratory, vasomotor, and other functions vital to life. This is what takes over. when when you physically can't. This is your autonomic nervous system. These are things you don't have to think about doing, is what I'm trying to say. All right, the vessels in the scalp are not able to constrict as effectively as other blood vessels in the body. Thus, they bleed more heavily when injured, which can lead to shock if uncontrolled. All right, scalp injuries tend to bleed very, very bad. All right, it's going to look like a ton of blood, but because it's so vascular, a lot of times it's easily controlled. All right, and a lot of times when you go on scene, people be flipping out. Oh my gosh, I'm going to bleed to death, and they got a little bitty 1 centimeter laceration that they're bleeding like a stuck hog from. Okay. The reason for this is that the fascia, which lies under the scalp but above the skull, can rupture and become depressed and feel on palpation like a depressed skull fracture. Blood can fill the area between a depressed skull fracture and the scalp, making the skull feel normal and not depressed when you palpate it. A skull deformity itself does not cause disability or death. Rather, it is any underlying damage to the brain that leads to serious consequences. In short, the skull deformity presents no danger if it is not accompanied by brain injury, hematoma, CSF fluid leaking, or a subsequent infection. You can have an open or a closed skull fracture as well. Okay, closed means it's not exposed to the outside. However, you can have an open skull fracture where you can actually see the brain. And every time I've seen this, I always want to like poke it. I don't know why. Yeah, something like that. I just want to like touch it and be like, ooh, I touched the brain. I think that would be cool. It's probably psychotic or something, but you know,
Yeah.
to each their own.
Sounds millennials.
Nobody asked for brain hush. Both conditions can cause increased pressure inside the skull and decreased perfusion of the brain, resulting in inadequate delivery of oxygen and glucose to, and the removal of carbon dioxide and other waste products from the brain tissue. All right, so traumatic brain injuries can occur from penetrating trauma, blunt trauma, or a secondary injury. Like we said before, brain injuries can be opened or closed. Continued brain damage resulting after the initial injury is called a secondary injury, okay? So your primary injury is the trauma. On this right here, it's the baseball hitting the guy in the head, okay? That's blunt force, which causes a skull injury. The hematoma is pressing on the brain tissue. You're gonna have a loss of consciousness, all right? Respiratory and circulatory changes can occur. You're gonna have signs and symptoms, decreased mental status, deformity of the skull, drainage of spinal fluid or blood from the ears or nose, discoloration around the eyes, hematomas, and brain swelling lead to increased pressure inside the skull and compression of the brain tissue. All right, it's pretty much going to be your secondary injury right there. All right, there's nothing that an EMT can do to reverse the effects of brain damage done by a primary brain injury. All right, the primary brain injury is the result of trauma to the brain that occurs at the time of insult from a direct impact, acceleration, deceleration, or a penetrating wound. All right, secondary brain injury can be worsened by hypoxia, hypercarbia, hypoglycemia, hyperglycemia, hyperthermia, and hypotension. Hypotension and hypoxia are the two conditions most critical to prevent. It has been reported that when hypotension and hypoxia occur together as secondary injuries in the brain injured patient, a 75% mortality rate occurs, which is a significant increase in overall mortality from the brain injuries. In fact, just a single episode of hypoxia has been associated with a 150% increase in overall mortality. Okay?
Does hypertension start at a systolic of 140?
Yes.
What's hypercarbia?
High blood pressure, I think.
Carbia?
Hypercarbia. That was the second one on that.
Uh-huh.
I mean carbohydrates, yeah, like sugars,
Carbohydrate? No.
hypercarbonate.
Look it up. It's in your book.
You don't know?
Oh, I know.
She don't know.
You sure?
But what good is it going to do for me to tell you when you can look it up in the book?
I'll quit wasting your time all over.
Emergency care of a traumatic brain injury patient, regardless of the cause or type, should focus on preventing or limiting secondary injury by establishing and maintaining, what is it?
It's too much carbon dioxide in the blood.
So it's not sugars and simple carbs, right?
Yeah, that would be hyperglycemia.
Mhm. To minimize secondary injury, you need to maintain a patent airway, adequate ventilation, SpO2 equal to or greater than 94%, systolic blood pressure above 90, normal body temperature, and a normal blood glucose level. Seizure activity in the brain, traumatic brain injury patient can lead to worsening of the brain injury, increased hypoxia and hypercarbia. What does that mean?
Means too much carbon dioxide.
Carbon dioxide levels. Okay. One way you could have figured that out is what does hypoxia mean? You always see hypoxia and hypercarbia together.
What does hypoxia mean?
Yeah, what does
Not
hypoxia
enough
mean?
oxygen.
Not enough oxygen. Okay, so if you're not getting enough oxygen, you're gonna have too much what?
CO2.
Carbon dioxide.
I wonder if plants have the opposite. Got like hyperoxia and then hypocarbia. You know what I mean? It would be the exact same thing,
Right.
just reversed.
Well, I don't know. I've never
They
really
don't.
thought about it.
I wonder if plants have EMTs.
Yeah, botanist.
Environment.
Yeah.
Now, how would you stop a seizure?
From your perspective,
Yeah, it says stop seizures as quickly as possible. How do you do that?
ALS backup.
So we can't do anything.
No.
I'm gonna stop it as quickly as possible.
What would you guys do?
Give them anti-seizure medicine, like Valium or Ativan, Versed, whatever your place carries. It differs very widely around here. We carry Valium.
And what would we do while we're waiting on you?
Waiting on us, make sure they don't hurt themselves even more, make sure they're getting the oxygen.
So like restrain them if we needed to?
No, I wouldn't
Don't
restrain them.
restrain a seizure.
Just got the basics.
Yeah, ABCs.
Somebody that's shaking when they're restrained, they're gonna hurt themselves more than under restraint.
Yeah. Just
Okay.
make sure they can't like hit their head on the side of the truck or on the floor.
Swallow tongue.
How would you
Whoa,
do
whoa,
that
whoa.
though?
Who the hell said swallow their tongue?
Me.
No. It is physically impossible for you to swallow your tongue unless you cut it out of your mouth and swallow it.
I think that's what he was talking about. He was talking
No,
about
you
he's
cannot.
gonna swallow their tongue. He's gonna cut it out.
No,
and he's gonna swallow it.
If a doctor is removed, I had a little piece of meat.
You cannot swallow your tongue, homie.
Well, you're saying if they did a surgery and removed that bottom part, then they could?
No, they can't. It's still attached in the fucking back.
Prove it wrong. Do it.
It is physically impossible for you to swallow. Please don't ever say that
Then why
again in
did
this
they-
class.
Then why did they make a thing though where they say like stick a walt in his mouth or whatever?
Who the fuck said that?
No. I'm
Joe
saying,
Blow
like,
on the street? That's good medical advice to
But hey,
take.
seriously, if you don't want them to hit their head on the truck or whatever, how are you gonna prevent that unless you're gonna restrain them?
Put a pillow under him. Put a blanket under him.
What if they're... I mean, does that happen? Or
Put a
I've never
pillow
seen
on
a
either
seizure. I
side.
don't know.
It's usually not that bad. It's not that bad. Brandon, you have hurt my heart. Like, I have no... Jesus. Increased hypoglycemia and a higher index of core body temperature. Read in your book. We went over that. I specifically said in the seizure chapter that it is physically impossible
No, I'm reading,
to
I'm
swallow
trying,
your tongue. I'm just saying.
no, I'm trying to find where the saying comes from. as
Well,
in
I don't know, but
so.
that's the dumbest shit I've ever heard. And people say it all the time, but however, don't fucking do that. That's like an old wives' tale and stuff.
No, I mean, I'm just saying I was going to, I'm just saying.
Don't stick your finger in your mouth. That's
For God's sakes, you're gonna become back nubby. Compression of the brain causes it to dysfunction, pushing the brain downward and out of the foramen magnum or through the tentorium compresses the brain stem, destroying vital functions, including the heartbeat, respirations, and blood pressure, because all of that activity is in the brain stem. Posturing, decorticate, also called flexation. All right, here's an easy way to remember this. Decorticate posturing. Look at me. Their arms go into their core. Okay? This is what they're going to do. It's an ingrained thing.
The other one go like backwards.
Yeah, that other one, like.
The other one, it goes out. That's decerebrate posturing. Their arms go out, they flex their back.
So decorporate, it goes to the
Decorticate,
core.
decorticate goes to the core. Decerebrate goes out. Okay? Decerebrate, also known as extension, is also known as non-purposeful movement. None of these are purposeful, okay? You'll only see them with brain injuries. Sometimes when they have really, really bad seizures, you'll see it. Cushing's reflex is increased systolic blood pressure and decreased heart rate. You should know that. I advise you to learn that. It will be on the test. Herniation is an extremely serious and potential deadly condition that most of the time we can do absolutely nothing about. Severe brain injury can occur with or without wounds to the head. A lack of wound to the head does not indicate a lesser brain injury, whereas an open wound to the head does not signify a more severe brain injury. All right. Diffuse axonal injury is the most common in car crashes and pedestrians who have been struck by a vehicle. Specific types of brain injuries, including a concussion, which is the temporary loss of the brain's ability to function, contusion, bruising or swelling of the brain, hematoma, pooling of blood within the brain, and a laceration or tearing of brain tissue. Can be mild, moderate, or severe. Holy crap, computer, come on.
That would be considered closed.
Yes, because the brain is not.
So the brain is basically
Yes.
no.
In a closed head injury, the scalp may be lacerated, but the skull remains intact. If you can poke their brain like I want to do, it's open. Oh, there's his brain. Like to poke it. I probably need to see a psychiatrist or something. Like, I just think that would be amazing. Be like, hey, dude, I touched your brain.
Normal human curiosity.
Is it?
Yeah,
So I'm not like
I like to touch weird things.
I'm not like a psycho or anything. I don't know. I can already see where that's going. It's right all over your forehead.
You don't want me to tell you?
I kind of don't, but
You
go
don't?
ahead.
Oh, go ahead. What if, okay, you had a person who's conscious and you just removed their cap off their skull and you got their whole brain let out in front
You've
of
seen
you?
a movie.
Have not.
Silence of the Lambs.
I've seen that, yeah.
Yeah.
But this isn't exactly from that. And you're just like, okay, talk through like your life story, like take me through all your memories and everything. Or have them talk about something. Just don't stop. Just keep on talking. And then just poke.
That's
just see what
actually how
happens.
they
Like what
do
happens
it.
if I poke the front?
That's
What
actually
happens
how
if-
they do some brain surgery.
Really?
Yes. Like Parkinson's, there's a specific place in your brain that makes you shake. All right, and they will keep you awake while they go in that part, and they'll give you like things to name. It'll be like a picture or whatever. It'll be like a ball, a car, and if you can keep saying those things and the shaking stops, they know they're in the right place. Yeah, it's really, really neat.
That's interesting.
Yeah,
Another thing.
Almost makes me want to be a brain surgeon.
Another thing,
not me.
your brain actually doesn't feel pain.
Yeah.
Your brain doesn't feel pain.
So there's.
Like that's why you can be awake. They just give you a little deadener in order to open
So
it
you
up.
could like make sure no one's around and just poke them and they wouldn't know.
Yeah.
Yeah. You can't feel it. There's no nerves.
Yeah.
That. Hey, listen to your boy Brandon. He's gonna.
As much
Let's
crap as
go
he's been spouting out today about putting
Today, I said one thing. I give you a sandwich.
that makes it better. You gave me a sandwich and then you said a load of crap.
Okay.
24-hour old town.
Exactly.
Hey, it was still
Exactly.
pretty good though. Ain't gonna lie.
It was pretty
They're
good.
being the cooler.
He came in here, he's like, you want the sandwich? I was like, yeah. He's like, I made it. And I was like, never mind. Signs of simple concussion might include momentary confusion, confusion that lasts several minutes, inability to recall the incident and sometimes the period just before it, which is retrograde amnesia, and after, which is anterograde amnesia. They will ask repeated questions about what happened, and honey, they will ask you the same thing 100 times.
I saw that on a show, it was the New Orleans one. What's it called? It's on YouTube.
Night Watch?
Yes, Night Watch. And this
That's on
guy
A&E, homie.
he was on well, it's on YouTube as well. He was on a skateboard. You can get it for free on there. You don't have to pay for it. He was on a
I already have
skateboard
it,
and he
I'm
got
not
hit
just-
by a car on a skateboard and he had this head injury and just kept
Mm-hmm.
on asking him, "What? Whoa!"
Yeah.
And then said, "Dude, calm down. You're
Right.
in an ambulance. You had a head injury. You got hit by a car." He's like, "Oh, okay." 5 seconds later, "Hey, wait, what's going on?
I know.
What happened?"
It's crazy.
Yeah.
And sometimes you think, like, do they really, like, I just said this
Right.
5 seconds ago. Like, what?
Yeah.
Yeah.
Does it really just
Yeah,
memory
it
of a
really- yeah.
goldfish? It's
Uh-huh.
like 6 second
Yeah.
memory.
I had a massive confession when I was like 13 years old.
Is that what's wrong with you today?
But I kept saying the same thing over and over. That's how my parents figured out there was actually something wrong.
Right. Yeah.
Like that.
That's one of the more common signs and symptoms is you ask the same questions over and over
Did
again.
you realize you were doing it, or
I don't remember any of it.
oh, so you don't have any memory of
I've lost
that
like
whole?
18 hours of my life.
I've only had one bad hit while I was in football and everything kind of went black. Woke up in the hospital. That's about all I remember. They said I was on the ground for like a good 3 or 4 hours trying to like check me out. That's about it.
3 or 4 hours?
Like during the game, I mean like as in like an hour on the field trying to like get me to wake up, waiting on the ambulance to arrive.
A fucking hour?
Yeah,
For the ambulance to arrive?
because they said I kept going.
They don't keep them at the ball field?
I've been knocked out a couple times.
We're at West Run football game. We were just chilling.
Big loud drum straight to the forehead.
My head went straight down, the dude came on, but that's when I kind of just blacked out.
So that's why I do arm wrestling. That's one of the only sports you're not gonna get a head injury.
Have
You
you
might break
seen-
your arm.
Yeah,
but-
that's why. Have you seen those videos?
I don't
on
mind
YouTube?
breaking my
oh
arm.
my gosh,
I
y'all, that
want to break
freaks
your
me
arm.
out.
You have to like get to a point mentally where you're like,
No, mm-mm.
your bones will break before mine.
No, mm-mm.
But I'm not gonna get head injury. So
I've seen the
yeah.
woman when I like some I can't remember what it was. She did like a championship thing and it went.
Yes. Oh my gosh.
I saw her elbow. and I was
It's the humerus that always breaks. It's never the radius or the ulna. It's always this one because it puts a spiral pressure, and that's why we don't do this. Everyone thinks that it's more like there's like 3 basic techniques. You get like a top roll and a hook and a shoulder press, but there's also like a flop wrist press and a king's move, and it's like a miniature martial art. But we're trying to not break our arm and still do it.
Well, I would suggest you not break your arm.
Yeah.
All right, you can have mild to moderate irritability or resistance to treatment, combativeness, inability to answer questions or obey commands appropriately, nausea, vomiting, and restlessness. Signs and symptoms of contusion include the initial signs and symptoms of a concussion and possibly a decreased mental status, paralysis, unequal pupils, vomiting, alteration in vital signs, and profound personality changes, especially if it's in the front. The front of your, the frontal part of your brain is where your personality is. Subdural hematoma. There's 2 types. You have an acute, which signs and symptoms begin almost immediately after the injury. Then you have an occult or chronic. The bleeding continues over time and the signs and symptoms don't become apparent for days to weeks after the injury. Usually when we go to a fall scenario, like if we respond to a fall, we will usually ask, have you fallen in the last couple of weeks and hit your head? Okay, this is the reason why we ask that. All right, any patient with an abnormally long blood clotting time, which prolongs the period of bleeding, is particularly susceptible to a subdural hematoma. And this is actually what it looks like. If you do a CT scan, that part right there, the hematoma, will actually be white. That's how they can see it. The rest of it will be kind of a grayish color, gray to black, and then that hematoma part will actually be solid white. Like you don't have to be a neurologist to figure out, oh, they're bleeding in their brain. Now, you probably need to be one to figure out if it's a subdural or, you know, one of them other matters. All right, signs and symptoms of a subdural hematoma include weakness or paralysis to one side of the body, deterioration in level of responsiveness, vomiting, the dilation of one pupil, abnormal respirations or apnea, possible increased systolic blood pressure, decreasing pulse rate, headache, seizure, confusion, personality changes. All right, signs and symptoms of an epidural hematoma. Decreased mental status, loss of responsiveness followed by the return of responsiveness, then a rapidly deteriorating responsiveness. Okay. Severe headache, fixed and dilated pupils, seizure, vomiting, apnea or abnormal breathing pattern, systolic hypertension, and bradycardia. This is your Cushing's reflex. And posturing. All right, this is your decorticate or your decerebrate posturing. Immediate surgical repair is needed in case of an epidural hematoma. Treatment early, the prognosis is generally good because underlying brain damage is usually minimal. And usually what they do, what I've seen them do, is they'll go in there and they'll drill a little, what they call a burr hole, and they'll drain all that blood out. Huh?
Just like kind of like to alleviate pressure.
Yeah, it's like a DeWalt drill, just like you get at Home Depot. They go in there and zzz, zzz, and that blood will come pouring out usually. All right, the bleeding expands rapidly in a small space, causing a dramatic rise in the intracranial pressure, which is why you see all those other signs and symptoms, the pupils, the blood pressure, the heart rate. All of those things, it's not because of the bleeding, it's because of the bleeding into that small space. The brain has nowhere else to go. If your patient has a subdural or epidural hematoma or brain laceration, their blood pressure is dropping, the pulse pressure is narrowing, and their heart rate is increasing, you must consider that they could be bleeding from somewhere else in the body. All right, Matt immediately performs inline spinal stabilization and uses a jaw thrust maneuver to open the airway as Lewis prepares to suction the airway. The patient has bleeding from the nose, a hematoma over the frontal area of their head, and many abrasions to his face. His breathing is deep and rapid. His radial pulse is strong at about 60 per minute. The patient responds to pain with non-purposeful movement. What indications are there of a traumatic brain injury here?
Movement and
The non-purposeful.
Okay, what else?
bleeding from the nose.
Bleeding from the nose. What about that hematoma? Abrasions to the face. Non-purposeful movement responds to pain. What additional information do they need to obtain through their assessment?
Blood pressure.
Okay. What is something else on his face that you can look at? Marcus, you were talking about it earlier.
His pupils.
Pupils. Remember, the pupils are the eyes of the soul, and they can tell you a whole lot of things. Don't forget to check their pupils, okay? What are the treatment goals for this patient? You gonna stand around and sing Kumbaya while you package him up, or are you gonna package him with a purpose and get out of there?
Gotta get out of there pretty quick.
Yeah, you need to get out of there pretty quick, okay?
Load and go.
Yep. This is not a stay and play. This is a load and go.
Just let it lay there for an hour, wait for the ambulance.
I think you should. It's probably.
What's the quickest way you can bleed out? Like what artery?
Aorta. Like literally seconds.
Okay, pretty good.
You have to get through the roof cage, right?
Your aorta, like if it's got a weak spot, it can just pop. And mine could just pop with me standing here and I'd be dead on the ground.
How's that happen? Does that actually happen?
abdominal aortic aneurysm. Does that sound familiar? I think you should go with
I
that.
didn't know that.
Uh-huh.
Abdominal aortic.
That's that pulsatile mass in the belly that you feel. It's the abdominal aorta bulging out. Seeing size up. Alright, unresponsive or altered mental status suggests head injury. Signs of head injury can be apparent or they cannot be apparent. Never assume that a mental status change in a trauma patient is due to drugs or alcohol intoxication. Okay, especially in trauma patients. Well, all patients, okay? You're going to encounter those people, but however, you need to rule out other things before you rule that in. Alright? This is what a star into the windshield looks like. Some people ride around with this all year long, okay? You need to know, was that there before you had the wreck? Sometimes you'll see blood, hair, pieces of skin stuck in there. This is not a good sign. This is one of the things that we look for and document if we see it or don't see it. Signs of head injury might include bleeding from the scalp or face, or an apparent mechanism of injury, such as a fractured windshield at the scene of an automobile crash, a deformed helmet at a crash involving a bicycle or motorcycle, or evidence of a fall. Alright, so our primary assessment: maintain inline stabilization, establish airway, jaw thrust maneuver, alright, especially for trauma. Trauma, we always use the jaw thrust. Maintain their SpO2 at or above 94% and use positive pressure ventilation if you need to. Alright. Alright, maintaining that airway and oxygen is vital because head injuries can become worse if there's inadequate supply of oxygen to the brain. Remember, just one episode of hypoxia increases their risk of death by 150%, which is a lot. Keep in mind that head injuries often involve injury to or blockage of the airway. Yeah, he got some. Somebody. Yeah, they do that because if you leave the eyes open, they'll dry out. But part of her lip is gone. I see them teeth is hanging out. Looks like that nose has got a real bad cut right there.
And you want to find the lip and see it, right?
At that point in time, I'm really not worried. The way she looks, I'm not worried about her lip. She might be later on, but as of right now, the lip is the last thing. She can have plastic surgery for all that. I'm worried about her living or dying at this point. I don't give two shits about her lip, to be honest. Alright, head injury. We use the IPU. Are they alert, verbal, painful, or unresponsive? Okay. Jesus, this computer is slow today. Alright, what now? Okay. In a pre-hospital setting, the numeric values on the scale are not as important as the types of responses to specific stimuli. Talking about your GCS scale. It's a more precise way to determine the mental status, alright? GCS is measurement of the patient's eye opening, verbal response, motor response. Here it is. If their eyes open spontaneously, there are 4. If they open to verbal commands, there are 3. If they open to pain, it's a 2, and no response is a 1. Verbal, if they're oriented and converse, there are 5. Disoriented and converses, there are 4. Inappropriate words, 3. Incomprehensible sounds, 2. No response, 1. Motor response. Obeys verbal commands, there are 6. Localizes pain, 5. Withdraws from pain, 4. Abnormal flexation in response to pain. This is your decorticate and your decerebrate posturing. You get a 3 for decorticate and a 2 for decerebrate. Okay, decerebrate is worse than decorticate. And no response is a 1. You can be dead and have a GCS of 3. Okay. A patient with a head injury might not complain of pain or other symptoms of trauma. Therefore, it is extremely important to perform a complete physical exam of the patient with a head injury to identify signs of trauma and injury to other areas of the body. All right, use extreme care in checking the patient's head. Be careful not to jab or apply pressure to the skull if there are depressions or deformities, okay? We just want to palpate very gently and look and feel. We want to palpate for deformities, depressions, lacerations, impaled objects around the head and the face. All right, we will do this around the forehead, down the nose, on the cheek area, around the jaw. Check the patient's pupils with a bright light, your pen light. Are they equal in size? Do they react equally? Both pupils should constrict the same when the light is shined in only one of the pupils. This reflex is the unstimulated eye is known as consensual reflex. If one or both pupils are fixed and dilated, this can signal an increase in pressure in the brain. Check the eye movements. Can they track your movement? All right. Is one eye positioned downward and outward? Are they looking the same way? The ears and nose. Check both ears for leakage of blood or clear fluid. A fracture of the base of the skull can cause both. Battle signs is a purplish discoloration or bruising of the mastoid area behind the ear. It is a delayed and late sign of a basilar skull fracture. Check the nose for leakage of blood or clear fluid and indicate the skull fracture or intracranial pressure. They will also have what we call raccoon eyes. They will have two black eyes. Okay? It's also a late sign. All right, motor sensory assessment. To examine motor and sensory function of an alert patient, check their ability to move their fingers and toes. Have them squeeze your fingers with both hands simultaneously to test for equal grip strength. Ask the patient to tell you which finger or toe you are touching without watching what you are doing. Pinch each extremity and ask if they can identify the pain. Ask if the patient feels any weakness on one side of the body compared to the other. Low blood pressure. Very early in a patient with head injury is almost always due to bleeding elsewhere in the body because there is not enough space in the brain to permit enough bleeding to reduce their blood pressure. Okay? So if you get somebody with a high systolic blood pressure, it means increased intracranial pressure. Somebody with a low blood pressure, they're hypotensive. That means they're more than likely bleeding from somewhere else. All right, your secondary assessment. We want to check our vital signs. Vital signs are very, very important, just like we talked about blood pressure there. Your pulse. Increased rate indicates another source of bleeding. Decreased rate indicates increased intracranial pressure or severe hypoxia. All right, the patient might display several different respiratory patterns if the brain is compressed from increased intracranial pressure resulting from swelling and or bleeding inside the skull. The respirations might be extremely fast and shallow, completely irregular, or even absent, or apnea. A sign of severe head injury is increasing cranial pressure, and possible herniation is the Cushing's reflex, in which the systolic blood pressure increases and the heart rate decreases. The respiratory pattern might also change and become irregular. Because where are all these things controlled? Where's your blood pressure controlled, your heart rate controlled, and your respiration, and your brain stem, okay? All right, if the following signs are present, consider hyperventilation at a rate of 20 breaths per minute. They have unequal pupils, fixed pupils, that Cushing reflex, increased systolic, decreasing heart rate, hemiplegia or hemiparesis, that means paralysis on one side or weakness on one side, decrease of 2 or more points in their GCS score. All right, you need to ask questions relevant to the head injury. Sometimes an injury to the head days or weeks after an incident in which the patient was knocked unconscious. They can re-injure their brain. When did the incident occur? What is the patient's chief complaint? Did they feel pain, tingling, numbness, or paralysis? Where? Have the symptoms changed since you had your accident? How did the accident occur? Did they remember what happened? Did they lose consciousness? All right, this information is critically important in assessing a brain injury. How long was the period of unresponsiveness? When did the When did it occur in relation to the injury? Were they immediately knocked unconscious? Did they take a blow and then 5 minutes later you found them unconscious? Did the patient suddenly lose consciousness and then gradually reawaken? Or did they pass out immediately? Were they moved after the incident? Has there been a previous injury to the head? If so, when did it occur? Was the patient knocked unconscious? Sometimes an injury to the head in which the patient was knocked unconscious can re-injure the brain days, weeks, or later. Thank you. My brain was just not.
Shut down.
Yeah. Dude, it's been a long day. Signs and symptoms of head injury include altered mental status, disorientation, all the way to unresponsiveness that doesn't improve or that continues to deteriorate. Irregular breathing pattern, increasing blood pressure and decreasing pulse. This is your Cushing's reflex. Obvious signs of injury. Contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Visible damage to the skull. Pain, tenderness, or swelling at the site of injury. Blood or CSF from the ears or nose. Discoloration, bruising around the eyes. In the absence of trauma to the eyes, this is your raccoon sign. All right, your battle sign. Absent motor or sensory function. Nausea and or vomiting. Vomiting can be forceful or repeated. All right, they will sometimes look like the Exorcist in the back of your truck. All right, they can have double vision, possible seizures. All right, both pupils should constrict the same when light is shined in only one of the pupils. His are not equal. That looks very weird. It looks kind of sweaty too. Maybe it's just oily. Anywho. Flexation posturing or decorticate posturing is a posture in which the patient flexes their arms across their chest and extends their legs. This posture could indicate an upper level brainstem injury. All right? Decorticate. If you got a posture, this is the way you want to do it. Decerebrate. Come on, computer. All right. Extension posturing or decerebrate posturing is a posture in which the patient extends both arms at their sides, extends their legs, and sometimes arches their back. Decerebrate posturing represents the lowest level of non-purposeful pain response, indicating a lower level brainstem injury. This is bad. Signs of brain herniation include dilated pupils, unequal pupils, dilated or non-reactive pupils. That decerebrate posturing. No response on motor examination, continued neurological deterioration. All right. Do not apply pressure to an open or depressed skull injury. Doing so can drive pieces of fragmented skull into the brain tissue. Do not put anything in the ears or up the nose, okay? You want to let that fluid that's coming out collect on a 4x4 or something, all right? You want to be prepared for seizures, all right? Continuously monitor their mental status, vital signs, and transport immediately. For other wounds, use gentle continuous pressure with sterile gauze only as needed to control bleeding. You want to reassess every 5 minutes. Pay close attention to the airway and mental status. Matt and Lewis recognize the indication of severe traumatic brain injury. Their priorities are continuing to manage the airway, breathing, and oxygenation while immobilizing the spine and preparing for transport. En route, they obtain a complete set of baseline vital signs and perform a complete secondary assessment. At the hospital, the patient is found to have a severe traumatic brain injury with a subdural hematoma and increased intracranial pressure. He is intubated, and there is immediately intervention to relieve the intracranial pressure. The patient is admitted to critical care. Despite rapid and appropriate care by all involved, his prognosis for recovery is poor, and it is for many patients with devastating head injuries. Alright, anybody got any questions about that? Yes, no, maybe? Sweet.